Hello, everyone. Alisa Brownlee with ALS United Mid-Atlantic. Welcome to our podcast. And it is my great honor to have with us Dan Kelly. He is a speech language pathologist at the Weinberg Jefferson ALS Clinic. And thank you for joining us, Dan. If you can introduce yourself, tell us what you do at clinic.
Yeah, thank you, Alisa. I'm Dan Kelly. I'm a speech pathologist from the Jefferson Weinberg ALS Center in Philadelphia. I've been with the center for approximately 10 years, at Jefferson for a total of coming up on 19 years.
Wow.
I work in the clinic primarily as a speech pathologist. If one is wondering what exactly a speech pathologist does in this setting, we specialize in speech, communication, swallowing, and occasionally language when that's needed.
So, our topic today is going to be swallowing. We have been fortunate enough to have a podcast with Amanda Kuth, who talks about communication issues. And then Tony did a podcast with the speech language pathologist from Meridian about augmentative and alternative communication options. So we're going to be talking to Dan today about swallowing issues, a topic that I don't see a lot of. A lot of times the focus, at least on the internet, is communication issues, but swallowing issues are critical. So is there a medical terminology for swallowing issues?
There is a medical terminology for difficulty in swallowing, and that is, we refer to that as dysphagia. It refers to any kind of difficulty in swallowing, be it food, liquids, or saliva. So it's quite common in ALS.
So can you explain the traditional swallowing process? Like, I mean, I take the food, I eat the food, but there's a medical process, and can you explain that and so that people can understand the swallowing process and then how it relates to ALS?
Yeah, so swallowing is actually a pretty complex and dynamic process involving 3 different stages. Um, it also involves more than 30 muscles and 6 cranial nerves. The first stage is the oral stage, which involves chewing, moving food from the front of the mouth to the back of the mouth. The second stage is the pharyngeal phase. It's a bit more complicated. That is sometimes experienced by individuals as the swallow reflex. That is where food is transported from the mouth over the airway and through the throat into the esophagus. And finally, the third stage of swallowing is the esophageal phase. That is where the food is transported from the bottom of the throat into the esophagus all the way down to the stomach.
So 30 muscles. Gosh, I didn't even know that. So if, for example, I've heard people say, well, I get the food in my mouth, but then I have to take my finger. That's a different set of muscles than the esophageal, right? So I guess my question is you might have weak muscles here, but good muscles here?
Right. So in ALS, the muscles that control swallowing, they do weaken over time. And difficulty swallowing can be experienced in any one of these phases. The esophageal phase, not necessarily, because most of that is, or at least half of it, is affected by smooth muscles. That is
Okay.
not vertical muscles. Food may oftentimes stick in the mouth or the throat. Sometimes people will have difficulty moving food around their mouth, where they need to use their fingers to move food from the front of the mouth to the back of the mouth. Sometimes there can be coughing, choking, wet or gurgly voice after or during eating. And sometimes meal times they can become slower, more tiring.
So you mentioned eating, drinking, and saliva. Uh, we have a number of people who feel like they're constantly drooling. Why is that?
Yeah, so drooling, or what we call in the medical field is siluria, is a phenomenon that we see is not because, with the diagnosis of ALS that you are suddenly producing more saliva. It's because of the impairment of the sensory mechanism and also the motor function that prevents effective clearing of the saliva. There often are treatment options that are out there, medications being one of those. Usually we start with a low dose atropine drop under the tongue every 2 hours as needed. Then sometimes we can move towards medications that have anticholinergic effects, which would dry up the saliva. Sometimes can dry up the eyes and the nose as well. And then in some of the later stages, we look more towards Botox injections into the salivary glands. And the reason that I say that it would be more like late stages is we tend to use Botox in the stage where somebody is no longer using their mouth or for speech communication or swallowing due to the very low risk that there could be migration of toxin into the adjacent nerves and muscles. There are compensatory devices that are out there to also help with siluria, such as like a portable suction device, or sometimes we'll see people start to use absorbent cloths to dab.
Okay. So the one thing that I learned from you that I want the listeners and viewers to understand is when it comes to sialorrhea too, that is also tied into water consumption, correct?
Right. So it seems counterintuitive that if you're drooling a lot, why would you add more liquid to the mouth? However, continuing to stay hydrated is very important because dehydration a lot of times can exacerbate constipation, which is a big issue with ALS.
So if I have these issues, what are my options? Do I have to change my diet or like if I can't take thin liquids, what do I do?
Yeah, aspiration is something that we do see with difficulty swallowing. Aspiration is when food or liquid or saliva enters the airway and sometimes the lungs instead of the esophagus when swallowing. It can cause airway irritation and in more extreme cases, infection. Typically when somebody aspirates, you have a robust coughing reaction, but however, with a disease like ALS, you may not feel it all the time.
So what are some of the signs and symptoms of aspiration and how's that different from choking?
Yeah, that's a great question. So one of the most hallmark signs and symptoms of aspiration would be coughing. Coughing because something went down the wrong way, went into the airway. Choking is different, similar to aspiration, but when we talk about choking, we think more towards some foreign body being in the airway.
So going back to aspiration, you're saying it goes down the wrong way, but it goes into the lungs, and then what?
Yeah, it doesn't always go into the lungs. Aspiration can actually happen over a long period of time, and I think we do see that a lot with ALS. Even with that whole phenomenon of quote-unquote silent aspiration, somebody could be aspirating for years and not necessarily have any bad effects. The body, its overall reserve, is able to keep healthy time. So when aspirating, food or liquid enters the airway. So the upper airway goes through the vocal cords, sometimes into the trachea. It doesn't always make its way all the way in deeper into the lung fields. A lot of times, some of the complications with aspiration doesn't always mean pneumonia. If you were to look up aspiration and do a Google search, you'll be led to aspiration pneumonia and more of the extreme cases. With ALS, for people that aspirate, sometimes we'll see more of a stimulation of mucus production. Combine that with a weak cough can sometimes be a big challenge for people to clear their secretions.
So you mentioned like a portable suction, or is that how people would get rid of secretions?
Portable suction is an option for clearing secretions. It's not the only option. When it comes to aspiration or choking, sometimes suction is not always the best go-to option, just because we don't really know where in the airway that material is. We're taught in basic life-saving or BLS or ACLS when somebody's choking not to do a blind finger sweep because you can potentially push that material deeper into the airway. Same thing would go with suctioning or any type of other type of a device like a cough assist or anything else that you see out in the market.
So families should know the Heimlich, though.
Yeah, usually when I talk with patients about whether they should know the Heimlich or not, of course, it's something that's important and people should be trained in how to appropriately do that. But we usually talk about prevention. We don't want to get to a point where we need to rely on the Heimlich maneuver for patients.
Okay. Is there a risk of malnourishment with people with ALS?
Yeah, actually, malnourishment or malnutrition is a big uh, common struggle for patients with ALS. When the swelling becomes more impaired or tiring, people as an effect eat and drink less. Maintaining weight is pretty important with this type of a disease. It can actually have an effect on the overall status and progression of the disease. So that's why working with somebody like me, a speech pathologist, and also a dietitian can help manage this.
So weight maintenance is very important.
That's right.
And if you lose too much weight, then or you want to continue to maintain your weight, um, what are the dietary modifications that can be made?
Yeah, there are a few things that we can employ to help compensate for any difficulty swallowing. One of those things would be diet modification or diet consistency modification. What that looks like is changing the consistency of the foods that somebody would eat. Maybe talking about going to more softer, moist, solid foods or even pureeing foods. That can, in effect, help make swallowing a little more efficient, a little more comfortable. There's always a balance between modifying somebody's food consistency and then balancing their overall enjoyment, comfort, and maintaining a high quality of life. Another dietary modification, which is not always used, but sometimes can be effective, would be adding a thickener to liquids. I tend to use liquid thickeners within the context of somebody who enjoys eating, enjoys drinking. However, every time they take a drink of liquid, they start coughing and it ruins the meal. So if we try a liquid thickener and that alleviates that coughing and in effect improves somebody's overall enjoyment, then that's when I would use that. Traditionally, thickened liquids were employed to be used to prevent aspiration, but we've found that there really is not a great effect with thickening somebody's liquids.
So certain foods can be difficult to chew, right? Like rice and lettuce and things.
Correct. Usually, those are the first two that I usually hear about from people. Eating salads and eating rice; those are the top culprits. And that's when we talk about modifying foods or keeping a food diary of what's difficult to eat. That doesn't necessarily mean that we talk about eliminating that from somebody's diet. If it's something that somebody enjoys, we just look at the different ways that we can continue to eat that type of food so that we can continue to enjoy eating.
Well, I'd like to talk about a food diary. So you a person just takes a piece of paper and says, okay, and then you want to track that for how long?
Usually over a week. I usually tell people to go home and do that for a week and then get back to me either via email or over the phone. Sometimes it's the patient's spouse or a caregiver that would do that. Taking a food diary of foods that are difficult, foods that are well tolerated, and then also incidences of coughing or intolerance of different types of consistencies. And then we review that, and then we come up with a more solid plan of moving forward with eating and swallowing.
Well, I would imagine that could be important too for bowel regimen, for trying to figure out if something is causing constipation or not.
Yeah, that gets a little bit out of my purview. Usually I defer a lot of bowel regimen and constipation and some of the more dietary or supplemental uh, materials that somebody would eat to our dietitian.
And a dietitian is usually part of an ALS center. Um, However, if you don't have access to a center, you can certainly seek out a dietitian for those, like a bowel regimen and things like that. Um, but if I'm eating and I'm, checking my food diary, do you also ask them to time their meals? Like, how long is it taking to eat?
That is a very big area to cover with ALS, is mealtime. Typically, a mealtime should be about 20 to 30 minutes. If somebody comes to me and says that they spend an hour per meal, we talk about how that's 3 hours out of your day. And then we try to evaluate whether this is enjoyable for the person to do.
What if they can't? Like, it's taking an hour to eat, they're not getting enough calories, they're losing weight. What's the next step?
Yeah. So a lot of times, if somebody finds themselves with prolonged meal times, difficulty swallowing, or they feel like they're eating normally, but they continue to have unintentional weight loss, usually that is a sign of difficulty swallowing or just difficulty with just overall feeding in general. We tend to start to look at other options such as oral supplementation, usually guided by our dietitian. We can trial that. And then sometimes we can even talk about feeding tube placement, which is an area that deserves quite a considerable amount of thought and education.
I was fortunate to do a podcast a few weeks ago with Stephanie, our dietitian from Jefferson, and we do talk about feeding tubes. We have quite an extensive discussion, so users or listeners, excuse me, or viewers can certainly go back to our podcast history and seek that out. It was very educational. I know feeding tubes are scary for some people, and I think Stephanie put a lot of good answers in there. Is that what you experienced too? Like, people don't know about what a feeding tube is?
Right. Yeah. So Stephanie and I'd worked together on this process and introduced the idea of a feeding tube pretty early on in the disease process. And we're usually in the room together to discuss the different aspects of what that would look like and what life would look like with a feeding tube. It is a highly stigmatized proposition. I think most people view a feeding tube as something that you would consider more an end of life or late disease stage, but that's not always the case. A lot of times it's just another tool to help get the adequate amount of nutrition, minimize the risk of aspiration or complications of difficulty swallowing. Sometimes can facilitate medication administration. So that's cutting down the stigma is one of the most important things that we do, and that's why we do it very early to help with that decision making. At no point during any of our interactions at the Weinberg ALS Center do we tell somebody that you need to do this, and this is something that is going to help you, and we want you to do this, and we draw a hard line in the sand. We simply deliver all of the information, provide all the education to help that individual make that decision.
And it circles back to what we talked about when we first started about excessive drooling and things, that can be tied into water intake. And I've had some people tell me they got a feeding tube simply to keep up with their hydration.
Mm-hmm.
So it's not necessarily always for nutrition. It can be. But as a speech language pathologist, if I have a feeding tube, and can I still eat? Can you tell me if I can still eat?
No, that's a great question, and I think a lot of times changes the overall conversation with a lot of our patients. Once somebody learns that they're able to eat and drink as they are doing, in the present time of that conversation, I think that changes everything. So yes, one can continue to eat, drink. We usually evaluate what is the most effective way, the most comfortable way, because quality of life is really what our focus is.
So one of the things that we also should talk about is positioning, like sitting upright, right? Like, if you're trying to swallow, you don't want to be kind of like this, right? You want to be in an upright position.
Positioning is very important with swallowing. Unfortunately, sometimes with this type of disease, achieving the optimal position for swallowing is not achievable. So that's often something that we need to work through. But in general, with swallowing or difficulty swallowing, whether it's in the home or in the hospital, positioning is one of the number one things, and a lot of times the solution to a lot of problems.
I should ask also, when we're talking about swallowing difficulties and somebody is taking pills, can every pill be crushed, or do you have to seek out a pharmacist or you to say, yes, this is crushable, no?
That's right. So not every pill is crushable. Sometimes there are extended release pills that are not able to be crushed. If we are either looking to crush pills or modify that the way that somebody would orally take pills, or if we were to put them through a feeding tube, a lot of times we do have to do a review of medications and look towards different preparations of that medication if needed.
And is it the nutritionist that does that? Like,
It's a combination of a speech pathologist, dietitian, physician. We
Okay.
all lend a hand in that process.
Okay. And I've seen people who have Trilogy, BiPAP, whatever, using a nasal cannula. Can you still eat if you have that on? Like swallow?
That's a great question. So I think if we're looking more towards practicality and what our literature says, I think that most of the time our patients we will find a way for somebody to eat and be comfortable, and while also maintaining safety. There is plenty of literature that's out there that does look at the use of high flow nasal cannula or even non-invasive ventilation during eating and how that can increase the overall risk of aspiration. So there are risks. I think patient education of their particular situation is most important to make the best decision that works for the patient.
Okay, great. Is there any other things about swallowing that we should have talked about?
I think there are many things that we can talk about. I think
Okay.
one thing that I do tell patients is that when they do come to me is that they're never going to be surprised. Difficulty swallowing is something that presents itself. Usually the person knows about it well in advance of coming to somebody like me. So I think that's one of the things that's more reassuring to somebody. If somebody has a diagnosis of ALS, they get onto the internet and start Googling and trying to find out information, and they find every single symptom that you can possibly get with this disease, which would be loss of communication, loss of speech. Those are the loss of swallowing, loss of communication. I think those are the two big ones, and many people are expecting this to happen as almost an eventuality. So I think that's where we need to pull the brakes and start to provide education as to the different types of this disease and the way that looks. Just because Dr. Google tells you that you may develop the symptom doesn't always necessarily mean that you will. And if you do develop difficulty swallowing or difficulty with speech or communication, that doesn't mean that there's going to be total loss. A lot of times it's a manageable dysfunction. And that's why we're here to support our patients to help them fight with this disease.
And I say this all the time, seek out professional intervention, not Dr. Google. if you live in an area where you can't get to a clinic, try something virtual. Seek out professionals before any intervention, especially when it comes to swallowing. And there's lots of things that we can do virtually that we couldn't do before, or people said we couldn't do. So one of them, I know you do see sometimes virtual people at clinic, right?
We do.
Yep, that physically can't get to clinic anymore, but you can still tap into your professional team.
No, I think it's always important, just to reiterate, to always engage your professional and their respective specialties.
Always. Always. I can't, well, people go and buy things, and then we talked about that, just because an influencer or somebody on the internet says this works, it might not. And so you should seek out professional help before you use any kind of product.
Yeah, that's right. So yeah, anything that you see on the internet, any kind of gadget, it's always good to run that by your professional, especially when it comes to any kind of interventional device with swallowing, because now you're looking at intervening with the airway and can potentially cause more damage than help.
It's great. And Dan, if somebody needs to get a hold of you or would like to reach out to you, can you give us your email?
Sure, absolutely. I can give you my email right over this podcast. It's daniel.kelly@jefferson.edu.
That's great. And I appreciate your time today.
Thank you.
All right. Thank
I appreciate
you.
you talking to me.